Hello to everyone from Geneva WHO headquarters. My name is Tariq and I wish you very welcome to the regular WHO health emergencies briefing and global health issues. Today, as always, we have a number of guests here in the room and also a number of WHO experts online who will try to answer your questions. Providing apologies for the delay, I will introduce our guests here in the room, our speakers, starting with Dr. Tedros Adhanom Ghebreyesus, our Director General. To his right is Dr. Mike Ryan, Executive Director of WHO Health Emergencies Program. Dr. Maria Van Kerkhove, Director ad interim Epidemic and Pandemic Preparedness and Prevention, is also with us, as well as Dr. Abdirahman Mahamoud, the Director and Interim Alert and Response Coordination. Also with us is Dr. Deus Mumagizi, who is Director of Health Products Policy and Standards. Also with us is Dr. Adelheid Marshank, Emergency Coordinator for the Democratic Republic of the Congo Crisis, and also Andrea King, Acting Incident Manager and Health Cluster Coordination for Occupied Palestinian Territories. As I said, we have other experts online who may be called upon to provide answers to your questions. For those who wish to ask questions, please, you may already click icon raise hand, so we will have you in the queue when we come to that. With that, I give the floor to Dr. Tedros for his opening remarks.
Thank you, Tariq. Good morning, good afternoon, and good evening. Today, the WHO family is in mourning over the sudden passing of our dear friend and dear colleague, Aidan O'Leary, the director of the WHO polio eradication program. Aidan died suddenly last night from natural causes while on holiday with his family. He was an outstanding humanitarian who served tirelessly in the most difficult parts of the world. He joined WHO in 2020 after a career of services in the United Nations in some of the world's most difficult places, including Afghanistan, Gaza, Iraq, Syria, Pakistan, and Yemen. He embodied the ideal of service and solidarity across peoples and borders. His passing is a terrible loss for WHO and for all of humanity, but most of all for his family and friends in his native Ireland and throughout the world. On behalf of WHO, I extend my deepest condolences to them all. We will miss Aidan enormously, and we will remember him for his kindness, openness, and friendliness. He was a gentle giant in every sense. We're committed to continuing his legacy to realize his vision and ours of a polio-free world. Rest in peace, my dear friend. And as the Irish say, Eirish Jegorev Aanem Jilish. One of the last things Aidan was working on was preparations for 2 rounds of polio vaccination campaigns in Gaza, targeting 600,000 children under the age of 8. WHO is sending more than 1 million polio vaccines to Gaza, which will be administered in the coming weeks. The detection of polio in wastewater in Gaza is a telltale sign that the virus has been circulating in the community, putting unvaccinated children at risk. WHO is also supporting routine immunization and disease surveillance, including for polio. We need absolute freedom of movement for health workers and medical equipment to carry out these complex operations safely and effectively. A ceasefire, or at least days of tranquility during the preparation and delivery of the vaccination campaigns, are required to protect children in Gaza from polio. Since the beginning of this year, the Democratic Republic of the Congo has been experiencing a severe outbreak of mpox, with more than 14,000 reported cases and 511 deaths. Outbreaks of mpox have been reported in DRC for decades, and the number of cases reported each year has been increasing steadily. However, the number of cases reported in the first 6 months of this year match the number reported in all of last year, and the virus has spread to previously unaffected provinces. In the past month, about 50 confirmed and more suspected cases have been reported in 4 countries neighboring the DRC that have not reported before: Burundi, Kenya, Rwanda, and Uganda. Mpox outbreaks are caused by different viruses called clades. Clade 1 has been circulating in the DRC for years, while Clade 2 was responsible for the global outbreak which began in 2022. The current outbreak in the eastern DRC is caused by a new offshoot of Clade 1, called Clade 1b, which causes more severe disease than Clade 2. Clade 1b has been confirmed in Kenya, Rwanda, and Uganda, while the clade in Burundi is still being analyzed. At the same time, cases of Clade 1a have been reported this year in DRC, the Central African Republic, and the Republic of Congo, while Clade 2 has been reported in Cameroon, Cote d'Ivoire, Liberia, Nigeria, and South Africa. WHO is working with the governments of the affected countries, the Africa CDC, NGOs, civil society, and other partners to understand and address the drivers of these outbreaks. Stopping transmission will require a comprehensive response with communities at the center. WHO has standing recommendations on mpox, which include advice not to impose travel restrictions on affected countries. WHO has developed a regional response plan requiring $15 million to support surveillance, preparedness, and response activities. We have released $1 million from the WHO Contingency Fund for Emergencies to support scale-up of the response, and we plan to release more in the coming days. There are 2 vaccines for mpox that have been approved by WHO-listed national regulatory authorities and which are recommended by WHO Strategic Advisory Group of Experts on Immunization, or SAGE. I have triggered the process for emergency use listing of both vaccines, which will accelerate vaccine access, particularly for lower-income countries, which have not yet issued their own national regulatory approval. Emergency use listing also enables partners, including Gavi and UNICEF, to procure vaccines for distribution. WHO is grateful to Japan, the United States, the European Union, and the manufacturers for working with us on vaccine donations. We're working with all partners through the Interim Medical Countermeasures Network to facilitate equitable access to vaccines, therapeutics, diagnostics, and other tools. In light of the spread of mpox outside DRC and the potential for further international spread within and outside Africa, I have decided to convene an emergency committee under the international health regulations to advise me on whether the outbreak represents a public health emergency of international concern. The committee will meet as soon as possible and will be made up of independent experts from a range of relevant disciplines from around the world. Finally, last week I had the honor of attending the Olympic Games in Paris. As I joined fans from around the world in full stadiums, I was reminded of how far the world has come since the last Games in Tokyo, when stadiums were empty because of the COVID-19 pandemic. While COVID-19 is no longer an international health emergency, these games are taking place against the backdrop of many other crises in our world, including conflicts in Gaza, Ukraine, and Sudan, with the risk of a wider conflict in the Middle East. The Olympic Games won't make the problems of our world go away, but they are a source of joy, hope, and light in an often dark and divided world. They remind us that we are one humanity and that our commonalities are greater than our differences. The Olympic Games are more than a sporting contest. They are an expression of what it means to be human and a glimpse of what our world could look like when we come together in friendship. In the words of the Olympic Charter, the Games are about putting sport at the service of our harmonious development with a view to promoting a peaceful society concerned with the preservation of human dignity. When the Olympic flame is extinguished in Paris this Sunday, may it continue to shine as a beacon of hope for a more peaceful world. Tariq, back to you.
Thank you, Dr. Tedros, for these opening remarks. We will now open the floor to questions, and we already have a number of reporters wishing to do so. So we'll start immediately with Helen Branswell from STAT. Helen, please unmute yourself and please go ahead.
Thank you very much, Tariq, and my condolences to you at WHO for the loss of Aidan O'Leary. I would like some assistance understanding the outbreak of Mpox, the clade 1B outbreak. People have talked about a new variant, a new strain of the virus. Am I correct in thinking that what is being seen with clade 1B is like what was seen with clade 2B, the Applebeck3 mutations that indicate that the virus has been spreading in people, or is there something else? And is it more, is there any science to indicate whether or not it is more transmissible as a result of those changes? Thank you.
Thank you so much, Helen, for this. I think we have online Dr. Rosamund Lewis, who is a technical lead for Mpox. Maybe we can start with Dr. Lewis. Rosamund, if you hear us, could you please take this question?
Yes, good afternoon. Thank you very much, Helen, for the question. Indeed, clade 1B has demonstrated some mutations, one of which you have mentioned, which suggests that the virus has been circulating exclusively person to person, which is indeed what the evidence that is available, as this particular, these provinces and countries have not reported Mpox before September of last year in the case of South Kivu, earlier this year in the case of North Kivu, and just in the last few weeks, month, in the case of the eastern neighboring countries. So it is a virus that is transmitting exclusively person to person as far as we know. In addition to that, the virus has shown other mutations, which make it necessary to ensure that the correct laboratory protocol is in place to make sure that the clade can be discerned if PCR is what is being used. PCR is the standard for laboratory diagnostics, and there are different protocols. And so WHO has some weeks ago put out new laboratory guidance on the protocols recommended by WHO for detection of this particular strain. So the countries are in a position to detect the strain. That that support is being provided through the response of WHO with the support of the countries, in support to the countries. At the moment, there is no specific information that suggests that the virus, the clade 1B, is more transmissible per se. It is transmitting through sexual networks, interlinked sexual networks, and we know from the global outbreak that transmission through sexual networks occurs more rapidly It doesn't necessarily mean that the virus itself is more transmissible. However, as the virus does continue to spread, it is also spreading within families and through community contacts, through the other modes of transmission which we are familiar with, which is direct physical contact, face-to-face contact, which may involve exchange of respiratory droplets, and of course, what we call fomites, which are things such as beddings and towels, which may be contaminated. Sharing a bed, for example, in a family setting would also be a high-risk environment if someone in that family has mpox. So the virus is a new strain. It has been now confirmed and documented by scientists, a number of scientists, by countries, and by WHO. And these are the features that we are aware of so far of this particular new strain. As to whether it is more severe, so we've talked about transmissibility, which we don't know that it's more transmissible, but it is transmitting through an efficient mode of transmission. And as to whether it is more severe, we also don't know. It is definitely causing severe disease, and it is definitely causing some deaths, but most of the persons affected so far have been adults. And as you know, children are more vulnerable. So it is still difficult to say whether this particular strain is less or more severe than the standard clade 1, if you will. So that is something that we are definitely looking out for at the moment. It seems to not be more severe than the standard clade 1, but it's dependent on many factors and context in which it is currently circulating. So these two features are things that we don't yet have full information on, which is transmissibility and virulence. Back to you.
Thank you, Dr. Lewis. Dr. Van Kerkhove.
Yeah, thank you. Just very briefly, just to use this as an opportunity to thank the countries that have increased their surveillance across the African continent, within DRC, but across the continent as well, and to utilize the capacities that they have for PCR testing, for sequencing, and to plea for more. So for us to be able to analyze these viruses that are circulating, to do the analysis and the characterizations of the different clades, because there are different outbreaks of mpox that are happening, it is really important that that surveillance is strengthened, that it's supported, that the sequencing is conducted, and that that information is shared rapidly. So we are seeing that happen, and we would like to see more of that, because as you've pointed out in your question, we need to be able to characterize these viruses to really understand the detailed epidemiology, because this will help us to have much more precise and tailored comprehensive response as we try to prevent transmission, to stop transmission, to provide care for patients, but also to utilize appropriate medical countermeasures like vaccines that need to be utilized in a targeted way. So it's a plea and a thank you for the sequencing that's being done, and to ask for even more as possible, and for that to be shared so it could be analyzed by an international group of scientists which are meeting regularly to evaluate the ongoing viruses that are in circulation.
Thank you very much, both Dr. Lewis and Dr. Van Kerkhove. We have a number of questions, so let's hope we will go through most of them at least. So let's go to CBC and Lauren Pally from CBC. Lauren, if you hear me, could you please go ahead?
Hi, good morning, everyone. This question likely for Dr. Lewis again on the mpox front. In the 2022 global outbreak, there was really distinct chains of transmission. The MSM community was largely impacted. Can you talk about the demographics and the populations you're seeing in these current outbreaks in Africa, and if you're seeing any different trends? And just one other question on behalf of a colleague as well, if someone could also comment on what WHO is doing with the Olympics to help protect athletes, given the rising number of cases of respiratory illness and COVID-19 currently. Thank you.
Thank you very much. There are two different questions. Dr. Van Kerkhove.
Yeah, maybe I'll start with this one. So I'll start with the second question first. So I first want to point out WHO, through our mass gatherings team and many different teams, works with the International Olympic Committee and the hosting governments to set up and to support the safe operation of Olympic Games. We've done this for many, many years, and we're doing so now with the Paris Olympics. There's an incredible amount of work that goes on between our teams and the teams that are putting these on to take this risk-based approach and to mitigate any potential infectious diseases, COVID and beyond. There are so many people that have come together. The DG talked about it in his speech today. where these games are operating safely. And it is such a celebration of actually bringing people together in a world of conflict that we live in. So we did clarify some comments that I made yesterday at the Palais briefing related to COVID at the Olympic Games, but we need to put this into context. Of course, there are going to be circulating pathogens, and there is COVID-19, but there's also, like we see in the community. But the Games and the Olympic Committee, the government of France, many partners that are there, put in place so many different measures to protect the athletes, and not just the athletes, but those who are coming to witness the Games and to celebrate the Games. So we are very happy and very confident in the comprehensive approach that the International Committee has said. I said this yesterday as well at the Palais briefing, in the measures that have been put in place. So that's the first question. On the second question, I'll let Rosamond perhaps come in and answer some of that. I think what we would like to see is much more detail in our understanding of the epidemiology of the Mpox outbreaks. Like I've said, and like Rosamond said before, what we really need is to understand the different ways in which this virus is transmitting, looking specifically at the age breakdown of the affected populations. We do see some differences in the age profile of the cases in different countries. We do have some information about exposures, and we know that there are multiple modes of transmission. We see transmission between family members. We do see some zoonotic transmission, but we also see sexual transmission in sexual networks. So that information is really important for us to better understand. So again, we can tailor the approach. We can ensure that on the prevention side, we have very strong risk communication, community engagement that's taking place, that we work with our local partners, we work with CSOs, we work with NGOs, we work with many different groups to help get that message across where people are showing up for healthcare to prevent those infections, but also, again, to tailor the use of any of the interventions that can prevent severe disease, that can prevent death. So we need more detail, I think, on the epidemiology. And I do want to thank, again, the field studies that are ongoing, the work that is being done in each individual country. We need more support for this. The DG mentioned this as well. Financial support for Mpox is required. We need to scale up the response to really tackle this as a multi-country outbreak, particularly looking at Clade 1B, but also looking at the different Mpox outbreaks that are out there. And we, through our regional office, through our country offices, through our partners like Africa CDC and many others, I shouldn't name some if I don't name them all, really support what's happening in country. But we do need those financial resources to have a better understanding of the epidemiology, all the way through understanding the response, addressing research needs, et cetera.
Dr. Lewis, would you like very briefly to add something on a particular question?
Sure, thank you. Just briefly in response to the first question about demographics. So yes, we have noted just now that this virus is spreading through sexual transmission and through sexual networks. The DRC, Democratic Republic of the Congo, has good data on the cadres of individuals, if you will, in terms of their profession that are being affected by this. And whereas there was 1/3 of cases in the beginning of the outbreak were among sex workers, that proportion is now reducing as more people are being affected in the community. This includes students, businessmen, people traveling across the borders for different reasons, and those whose occupation is not reported. So we do know that this is transmitting through sexual networks, and we do know that this includes sex workers, which obviously there are commercial sex activities in the region, which include those necessary for survival, for income generation. And so everything that Dr. Van Kerkhove has said about risk communication, community engagement, and increasing access to vaccines all remains critical for this outbreak response. Some children have been affected already. At the moment, that proportion is not very great, but there are cases in areas such as internally displaced persons camps, as well as congregate settings. So it's a complex outbreak with myriad manifestations, and the response has to be contextualized, localized, to identify those at risk, and provide the information and resources they need to respond to this outbreak.
Thank you very much. We will move now to next question. Gabriel Emmanuel from NPR, and if it would be possible really to limit to one question only. Gabriel?
Thank you very much. I am again curious about this MPOX situation and wanted to understand when the emergency committee may be meeting and also where things stand in terms of getting vaccines to people on the ground as of now. Thank you.
So I can start again. So on the first part of your question, I'll just reiterate what the DG said is that the emergency committee will be pulled together as soon as possible. So we have a roster of people that we will be contacting, and we will arrange this as soon as possible. We'll let you know. On the vaccine side, I know my other colleagues may want to come into this. And so we are working with many different partners. Again, DG mentioned this in his speech, of working with many partners to look at donations that are coming, that are available, directed donations, or how this will be managed. And we're very grateful for those who are coming forward to provide those donations. We're also, I'll let Deuce comment on the link to EUL and getting vaccines in country, but just to highlight that once they are in country, there's a lot of work that is ongoing looking at the protocols, how these vaccines can be used in communities. There are many people on the ground that have experience with this and in country to do this, as well to make sure that we have the targeted use of these vaccines. So many different things that are underway, but maybe in being conscious of time, I'll pass over to Deuce to comment on that.
Thank you, Gabriel. Now that the Director General has launched the emergency use listing, we will be reaching out to the manufacturers and the applicants to submit applications for evaluation under emergency use listing. A team has already been put in place ready to review these applications, and they will be screened within 1 week, and the assessment should not take more than 1 week from acceptance into us, more than 1 month from acceptance into assessment. And thereafter, we shall convene the technical advisory group, or the TAG as we refer to it, within 1 week of the report being available, and the TAG will make a recommendation. Now, should that recommendation of the vaccine be positive, WHO is ready to share the assessment reports with member states to facilitate their authorization and acceptance in 2 countries so that then they can be available for use. Just to supplement what Maria and others have said, when these vaccines are available, we urge all clinicians, member states that are using them to continue gathering information so that we can actually gather all the information that is needed about the use of these vaccines. Thank you very much.
Thank you. Thank you both. Dr. Ryan?
Just very briefly, because when we come around to different outbreaks we face around the world, we've got various events that we face, be it a viral hemorrhagic fever, Mpox, COVID. The basic approach is pretty much always the same. There are certain key components that need to be put in place. We have got to really extend and improve the level of surveillance, case finding, contact tracing, our ability to detect and track this virus. We've got to focus on protecting communities, whoever they are, wherever they are, ensuring that communities have the knowledge that they need to avoid infection, that they have the resources that they need to avoid infection, that they have the countermeasures they need to avoid infection. We need to ensure that there's good clinical care in place and scalable care where it's needed. So both the hospital or the health system and communities need access to those countermeasures like diagnostics, vaccines, therapeutics, and that's been achieved through the medical countermeasure network. We also need research and development. We can't stop here. Some of the products we have are good, but they're not the final answer to Mpox. There's very good research going on new vaccine platforms, being sponsored by our colleagues at CEPI and others. There's a need for political commitment. Dr. Tedros is working with the regional directors and with Jean Kaseya at the Africa CDC and the African Union to bring the necessary political commitment to get because dealing with an outbreak requires a sustained effort on behalf of multiple governments. We all saw this in COVID. Where we lose is where there isn't that political commitment, where there's confusion, where there's lack of coordination. The world needs to, in this case, as it did for COVID and in other diseases, come together to make sure that we're doing surveillance together, we're supporting communities together, we're providing good clinical care, that there's access to countermeasures, that the research and development agenda is advanced, that there's political commitment, that there's coordination, and finally, and probably at this point, crucially, that there is financial commitment to stop this virus. I have to say, going back over the last 2 years, it was frankly amazing to me that even in the large-scale Mpox outbreak we had around the world, there was no funding made available for the control of that at international level. We're having to once again dip into the contingency fund for emergencies to begin the process. So while there are very challenging and interesting scientific issues to be addressed here, and it's very important that we have a better understanding of this virus, it's a virus that can be contained. It can be contained quite straightforwardly if we do the right things at the right time and we put all of our minds and put all of our efforts together. So countermeasures themselves, vaccines do nothing. Vaccination is what saves lives. And we need to make sure that we can deliver that on behalf of the people in the Kivus and in other places who were affected by this virus today. Thank you.
Thank you, Dr. Ryan. I understand that Dr. Lewis would like to add something briefly on the authorizations.
This is just a small comment, just for clarification, just for clarity, that the emergency use listing process, which begins, will accelerate access to vaccines, as has been mentioned. Just to note that 2 countries in the African region have already approved Mpox vaccines for emergency use. That is, Nigeria has approved the use of one vaccine, MVABN, and the Democratic Republic of the Congo has approved the emergency use of LC16 vaccine and MVABN. This is just to note that those countries have moved ahead with their planning on securing vaccines, and that discussions are underway to make that happen. That will not in any way impede the process of the emergency use listing, which is necessary as multiple countries are now reporting cases at the same time. Just wanted to be sure that for our colleagues online that this was clear. Thanks.
Thank you, Dr. Lewis. We will now go to German news agency DPA, Christian Ulrich. Christian.
Thank you, Tariq, and I'm afraid I will also stay with Mpox. Could you give us an idea whether you fear the spread would be in the neighboring countries of DRC, or could you quantify or be a bit more specific about what the risk is of a spread beyond African countries, like in 2022 to Europe or other parts of the world? Thank you.
Okay, let's start with Rosamund. Dr. Lewis, would you like to start on this one?
Thank you. Yes, I'm trying to work on the volume of my setup here. I will try and do that. The risk is risk. WHO does have a method of assessing risk, which can be low, moderate, high, or very high. And at the moment, the risk of further spread in the region is moderate for the general population, high in the Democratic Republic of the Congo. We are reviewing the risk assessment now to bring it up to date with the latest information. And so that will be made available shortly in new communications. Having said that, we've already seen that the virus is now rapidly been documented in 4 new countries that had never reported before. And we've also seen what can happen in the global outbreak that began in 2022, where many countries were affected in a very short period of time. So we can't predict for sure what will happen, but we can anticipate that there are different scenarios and need to be prepared for that risk and for further spread in the event that that does occur, which can occur either in proximity to countries that already have the virus, or of course at further distance through other modes of travel, whether it be road travel, or rail travel, air travel, or foot travel. So all those modes of travel can, of course, continue to contribute to the outbreak. We just want to be also very clear that the standing recommendations that have been in place since August of 2023 do not recommend specific travel measures. What is recommended is information to travelers and cross-border collaboration between countries on surveillance and on case management. Other specific travel measures, such as shutting down travel mechanisms or things like that, are not being recommended at this time. They have not been recommended since the beginning of the global outbreak. What we are looking for is supporting countries to support each other through cross-border work, which is necessary to stem the continuing spread of the outbreak.
I think very briefly, I just want to highlight the urgency that we are trying to get across today, right? There's a lot of things that are happening with Mpox. This is an outbreak that caused a global outbreak. We had a public emergency of international concern. There was some attention to this. The tension waned. There's an ongoing outbreak that's happening. We're talking about spread. This virus is being detected, particularly this clade 1b, which we know is more severe than clade 2, is being detected in a number of additional countries. There's certainly increased awareness. There's increased readiness in countries, which is excellent, and there is increased reporting. But this is detecting circulation, and this is something we want to act upon now. All of the things that can be done, and reiterate what Mike said, what Dr. Tedros has said, that this can be stopped if we actually put a concerted effort into this. We don't sit here and watch and wait, and we do not want the world to sit and watch and wait until, whatever that until is, to actually trigger some action. The time is now. The time was before, but let's talk where we are actually today and actually make the investment in Mpox that is causing significant challenges in many of the countries across the African region. We live in an interconnected world, and these pathogens do not respect borders. So I just want to get across the urgency that we're trying to say that the action is now, the time is now for us to take much more measures and provide much more support to the African region, to the countries that are affected across the entire spectrum, from surveillance to prevention to risk communication to clinical care to infection prevention control to R&D to the use of vaccines. It's now.
10 seconds. I think we've cast our minds back to the previous large increase of Mpox cases around the world, and we could sit here and say that the global scientific cavalry came to the assistance of the world and we stopped the outbreak. The outbreak of Mpox before, amongst MSM in the main, was contained by that community, by a community that was informed, a community that was aware, a community that was engaged, a community that was empowered, a community that took responsibility and engaged with government in order to get the resources they needed. So, again, I'm coming back. I don't want to poo-poo the science here. The science is important, and all of the work we're doing is important. But communities are at the centre of containing an outbreak like this, and we have seen that in the field in the past. It is some of these communities, and certainly in Congo, have been living in extremes. We're dealing with areas in which there have been active conflict for decades and decades. Communities have been through the mill. They've been through everything: measles outbreaks, meningitis outbreaks, cholera outbreaks, war. They're resilient, but they need to be able to be brought to the centre of this response. There are excellent NGOs on the ground, NGOs that have worked against HIV and others and made huge strides in reducing the incidence of HIV through awareness and education and access to antiretrovirals. So I think this is a community that we need to empower. These communities we need to engage and we need to invest. And we need to match that then with the power of science and the power of surveillance, as Rosamund and Maria have so wonderfully outlined. But I really want to keep emphasising this, that it's on the ground is where you stop an outbreak, on the ground with communities, with the proper teams, with the proper organisations, supporting a local community. And when we talk about the danger of international spread, it is relatively straightforward to stop a disease, even if it is spread internationally, if you know where the disease is, if you're able to detect it, if you're able to find cases, find contacts, treat those individuals who are affected in those communities, treat them with dignity, empower them, and they will help you to stop this disease. So I think we have to go back to the ABCs again, because sometimes in these situations we get lost, and we need to go back to basic principles of where epidemic containment begins and ends, and that is in our communities.
Thank you. Thank you very much. Now we'll have Paul Adepoju from The Lancet. Paul, if you hear us, please go ahead.
Yes, thank you very much. And my heart goes out to the WHO team over the loss that Dr. Tedros announced. I'm also sticking with mpox. About 2 years ago, I think on July 23rd, Dr. Tedros, you declared it a public health emergency of international concern, even though the board was unable to reach that consensus. If we look back, can you share what led you to make that decision and the factors that led to that? Looking at how this current outbreak is progressing, do you think a declaration can make any significant difference in how we respond? And are there any unique tools that are now available that can better help the world, and especially African countries that are directly affected, to better respond to this outbreak this time? Thank you very much.
Yeah, sorry, don't want to jump across the boss. Tedros will probably supplement, but Tedros exercises and executes his mandate under the international health regulation by constantly scanning the world, and his team scanning the world for events that are likely to be of international significance. That is done through event-based surveillance, through official reports from governments and others. That's happening on a daily basis, thousands of signals per day, hundreds of thousands per month, millions per year, that are sifted through by Abdi and his teams and teams all around the world. From all of that noise, Tedros must select those events for which meet certain criteria. And in the specific case of calling an emergency committee, what he's trying to determine is whether an event has reached a level where it surpasses the impact of other events in one of three key ways. One, is this a new virus or a novel virus, or is this an unusual event, unexpected in terms of its epidemiology? Has this disease or event crossed international borders? And will the containment of this disease require international cooperation and assistance in order to contain it? They're essentially the three basic criteria. And the committees that he brings together, the emergency committees, are asked those three questions specifically, and they address that through being presented to by various experts, asking questions, getting data, and they advise the DG as to that determination. As in all matters of human endeavour, one never gets a complete consensus. In fact, that's why you bring experts together. What you're not looking for is consensus. What you're looking for is diversity of opinion, and you want to get every point of view. Tedros must sift between that and then determine on the basis of the advice he gets, because it's the Director General who makes the declaration, not the committee itself, on the balance of good, on the balance of benefit, on the balance of public health risk. What should he do? In the case of mpox, and I must say, I very much agreed with him that based on the fact that the committee had no consensus, he had to make a judgment. And I believe that judgment was made on the precautionary principle that we needed to act collectively around the world, and that he needed to declare a public health emergency in order for the necessary action to be taken to contain that virus, which I believe has proven successful. Sorry, Tedros, I hope I haven't misrepresented you.
No, thank you, Mike. I think you said it all.
Press that on, sorry.
Which one? This one. You said it. Maybe to add to that, as Mike said, the emergency committee advises, and then since they were divided and there were some were in favor of declaring FIC and others against, but based on the analysis, we supported those who were in favor of having the FIC. So sometimes when a split vote like that happens, which is very close, then I could act as a tiebreaker. So that's why we preferred the declaration of FIC at that time. And going forward, the same thing can happen, by the way. We consider many factors, including the advice from the committee, and we can declare. So the same thing can happen in the future as well. Then on how it can benefit, if whether it benefited then or not, I think it did. It increased awareness, it mobilized stakeholders, and we saw cooperation and some progress also in the tools that we're now planning to use. So it really helped, and we hope going forward, if that's the case, and if it's triggered, we only trigger it because it can help in combating or managing the epidemic. So we will see now what of course we will convene the emergency committee as soon as possible, and we will follow the situation also very closely as we're doing now. And we will listen to what the committee says, and we will keep you informed. Tariq?
Thank you very much. Let's see if we could have one or two more questions as we are coming to the hour. So let's go to Maya Davis from CNN. Maya, please go ahead.
Hi, thank you guys, and my condolences again. Going back to the polio vaccines, just had a question about this for what the logistics are. I know there have been calls from your organization for ceasefire for safe deployment of these vaccines, but if this is not rendered a reality, what is the organization's plan to roll out these vaccines, and what does this look like? Thank you.
Thank you very much. So absolutely, it's a huge logistical challenge ahead to make sure that the 1.2 million doses of vaccines are deployed into Gaza, and that was what the team at WHO and UNICEF, along with the Ministry of Health, are working on very actively. It's the vaccines as well as the associated cold chain supplies that are needed to enter Gaza. So there are efforts underway in making sure that those logistics are aligned with permissions, the correct permissions to enter Gaza, as well as the micro-planning for within Gaza, which is a very detailed set of plans in order to roll out the vaccination campaign. So all of these are underway for both the logistics and the necessary permissions, and where the hope is that if everything lines up, these will arrive in time for the planned vaccination dates later this month, the first round to start on the 17th of August.
Thank you very much. That was Andrea King, who is basically heading the health cluster for occupied Palestinian territories. Let's go maybe to the last question. Imogen Folks from BBC. Imogen, please go ahead.
Yeah, thank you for taking my question. It's also about the polio vaccination campaign in Gaza. It's still a bit vague. Can you let me know, have you got the assurances that you will get everything in and that you will be allowed this absolute freedom of movement that you require?
I can't say with certainty that we have all the assurances at the moment, but it is a high-level piece of advocacy that's been worked on to get all the supplies and the necessary permissions to enter into Gaza for this vaccination campaign to be carried out successfully. The days of tranquility are required in the days leading up to and including the vaccination days, and that will be necessary in order to make sure that the health workers carrying out this vaccination campaign and the population are kept safe during this activity. So we continue to ask at every level that this be afforded for the population for a successful vaccination campaign. Over.
And to close, I think we have just one more minute to get to the hour. We can take Janice from Bloomberg, if Janice is still with us. Janice, please go ahead. We just need to, yes.
Yeah, hi, thanks very much. I did actually lower my hands because most of what I wanted to ask had been asked, but maybe if, seeing I have the floor, just as a long shot, do you have any sense, going back to the Mpox outbreak, any sense of what the fatality rate is? I understand that the sequencing and surveillance is tricky, but I've seen varying numbers on what this 1B the fatality rate might be.
Thank you, Janice. Do we have Dr. Lewis online?
Yes, I hope my audio is better now. So just to say that, yes, we have good data insofar as we were able to secure that data for reported clinically compatible cases versus laboratory confirmed cases. So overall, the case fatality ratio of reported cases in the Democratic Republic of the Congo is currently 3.6%. That is across all provinces and across all age groups. We do know that in endemic areas, which is central, north, and west of the country, that the case fatality ratio is significantly higher than in the east at the moment. It is higher partly because many more children are affected. So 3/4 of the cases are among children, and 88% of the deaths are among children under 15 as well. And there's an age gradient in the case fatality ratio. So infants have a high case fatality ratio of over 5%. Children under 5 have a case fatality ratio, which is a bit lower. Under 15, lower still. We have all this data online, but you can also look for that there. We can provide that link. And in adults, children and adults over 15, the case fatality ratio is lower than 3%. So we do have that information. In the eastern part of the country, where it is clade 1B, the case fatality ratio at the moment is just under 1%, and it remains lower than the other part of the country. As I said earlier, we don't know yet if this is because the clade is perhaps less severe as opposed to more severe in terms of clade 1B versus clade 1. But it's also because it's almost exclusively, at the moment, most cases are among adults. So we don't have that demographic of children under 15, under 5, and infants currently affected to the same extent. And therefore, we don't have the same number of cases leading to deaths, because those are the most vulnerable groups. However, there are also women who are pregnant who have been reported to have Mpox. That has leads to death of the mother in rare cases, and also loss of the pregnancy in other cases. So there are a number of significant medical, clinical, and public health impacts that can arise as the virus continues to spread. At the moment, just to summarize, the case fatality ratio overall in the Democratic Republic of the Congo is around 3.6%, higher in endemic areas, and especially in infants and young children, and lower in the eastern part of the country at the moment, where spread is more rapid through sexual transmission among adults.
Thank you so much, Dr. Lewis. And this will conclude our Q&A session. I will just give the floor now to Dr. Ryan, who wanted to say a few words.
Thank you, Tariq. And just to follow up on what Dr. Tedros said about our dear friends, Aidan O'Leary. Aidan was a very proud Irishman, but more a proud global citizen. He bore witness to so many conflicts around the world, and he represented all the values that make us proud to serve WHO and the United Nations. He also worked with UNICEF, UNOCHA, and others, and with the broader Global Polio Eradication Initiative. And my heart goes out to all our colleagues and friends around the world. I can't tell you the number of messages I've had today from all corners of the world about him. Myself and Abdi worked with Aidan in the front lines of polio eradication in Afghanistan and Pakistan for years. He was, as Tedros said, a gentle giant. He was the best of us. It's hard to express his courage, his tenacity, his determination to serve those who have least. Tedros spoke about the Olympics and peace. He believed, Aidan believed, that the true human values of compassion, of solidarity, of dignity and equity transcended the base human instincts we see today all around the world, of hate and selfishness and discrimination. We will miss you, Aidan, our friend. Thank you.
Thank you so much, Dr. Ryan, for these touching words. For journalists who didn't have opportunity to ask their question, please do contact media team at media@who.int, and we will do our best to assist you. Opening remarks from Dr. Tedros, as well as the video and audio file, will be sent to you, as always, in the next couple of hours. With this, I give the floor to Dr. Tedros for his closing remarks.
Thank you, Tariq. To the members of the press who joined today, please accept our gratitude and see you next time.